Hi, everybody. This is your documentation and reporting podcast. And this material is something that we would have done in class had we been able to meet. When we talk about documentation and reporting, we're talking about communication, which has to be effective among healthcare professionals so that patients can be safely cared for. We've got to be able to record what medications were given so that the next shift knows what time they were given. We've got to be able to record patient statuses so that we can compare that data when we're taking care of our patients. We have to be able to report to the next shift what has taken place. So all of this is very important for patient care. Ethical and legal considerations. The American Nurses Association Code of Ethics says that nurses have a duty to maintain confidentiality. We all know what HIPAA is from the client end. Some of you may know from working in healthcare. Access to patient records is restricted to only those who are participating in the patient's care. So as a nursing student in clinical, if you are not assigned to a specific patient, then you have no business to be looking at their health record. This is protected by HIPAA, and students, in addition to working professionals, are bound by the ethical code as well. And your instructors, when you get to that point, will certainly educate you on the do's and don'ts of documentation and getting into patient records. So to maintain confidentiality, some of these tips apply to everyday life as well. Not sharing passwords. Don't share your personal password for documentation. We have mostly electronic health records now. You should not be sharing your password for another student to log in and document. Make sure you log out every time you walk away from a computer. Make sure people can't see the monitor display. So family members should not be reading a patient's chart if you're in the hallway, or even in a room for that matter. Always shred documents when necessary. So if it's not an electronic health record situation, then those documents that contain a patient's name, as long as it's not part of the permanent record, would need to be shredded. For example, if you're writing down your assignment and you put any kind of patient identifiers, you would need to shred that document so that somebody couldn't see it later. Make sure that you know the facility's policy for correcting any kind of errors, which we'll talk about in a little bit, and follow procedures for sensitive material like somebody who has an AIDS diagnosis. That information is not put in a central part of the chart. It's a little harder to find so that it's not something that anybody can look at. So I want you to think for a minute about when can a client's record be shared, and I'm going to ask you to answer that question within Edpuzzle. Client records are really, really valuable, and they do become part of the patient's permanent record. They're legal documents that have to be kept for a certain amount of time, so they have to be treated in a certain way. The purpose of client records, charts, whatever you want to call them, is communication, as we've already talked about. Planning client care, so you can look at what is the care plan, what is the goal, what are we trying to do for this patient, where are we trying to get them, what's the end game here. Anytime there's an audit, for example, insurance companies looking at the charts to make sure that what they pay for was actually done and that it's documented in the chart. Research, education, which of course you'll be on that end of things as students looking at patient charts. Reimbursement, I talked about. Legal documentation. So if a circumstance goes to litigation, it serves as a legal record of what took place. Healthcare analysis, so looking at trends, medication trends, patient care trends, even documentation trends. Charts will be looked at. And it reduces the likelihood that patients will have to repeat information. It's not to say that they definitely won't have to repeat information, but it helps to have the record there so that they don't have to start back at the beginning of their story if it's already written there, you can go in with a certain amount of knowledge before you actually start taking care of that patient. Otherwise, they're going to go back to the beginning of the story. Well, I was admitted to the emergency room 2 nights ago because of ABC. The next nurse comes in, they have to tell the same story. They don't want to have to do that. We certainly don't want them to have to do that. So it gives us a picture of what's going on with the patient. So very valuable. And legal documents. There are different documentation systems that you may run across, and some examples would be narrative notes, where people just write freehand, like a story. This is what happened with the patient. There's problem-oriented charting, where you only chart on problems that the patient has, and you don't address anything that is normal. There are flow sheets, for example, where you would put vital signs so you can follow a pattern of what's happening. Focus charting, where you only chart again on the problems, focus on a particular aspect. There's charting by exception and electronic health records. Another type of data that's pretty popular is called SOAP notes, S-O-A-P. The S stands for subjective data, which you already know all about that, or also called the history of present illness. So it's what the patient is telling you the problem is. Objective data is what you assess, what you observe, you as the nurse. Assessment would be putting it all together and creating a nursing diagnosis, so putting a label on it, and planning. What are we going to do from here? What are we going to do about it? So what I want you to do is, using the SOAP note format, I want you to pull out from this scenario the subjective data, the objective data. You can try to put a nursing diagnosis label on it. Look through your NANDA approved nursing diagnoses located within your packet, and based on what she's complaining about, put it all together and try to put a label on it. And then possibly what a plan might be. I'm more interested in you pulling out the subjective and objective data, but I do want you to try to go through the whole thing so you can have an idea of what we're looking for. I wanted to mention what Joint Commission is for those of you who don't know, because we talk about Joint Commission approved terminology within the chart. So Joint Commission is an independent nonprofit organization that accredits and certifies healthcare organizations and programs within the United States. And the accreditation is recognized by it as a symbol of quality. So what happens is they have surveyors come into various facilities who want that stamp of approval. And they come in and they look at all kinds of things, from nursing care to charting, all kinds of things before they'll give their stamp of approval. And facilities want that because the general public knows that Joint Commission means quality. So they want that stamp of approval so that they can advertise that they've been investigated, and Joint Commission says, yep, they're a good quality facility. So it's a stamp of approval. It's not something, failing a Joint Commission inspection isn't something that's going to shut a facility down, but facilities do not want to lose that stamp of approval. Documenting nursing activities should always describe the client's ongoing status. So we want to see what the progression or regression of the patient's status is. It should reflect a full range of the nursing process. So there should be an element of assessment, diagnosis, plan, implementation, and evaluation. It may not be listed that way, but there should be evidence of the process. What did we find? What are we going to do about it? How are we going to assess? Are we looking at the outcomes? So there always should be some components, if not all, of the nursing process. And Joint Commission does look for that when they come in for inspections. So methods and forms will vary by facilities, and I have some examples. Admission assessment, nursing care plans, Cardex's, flow sheets, and progress notes are some examples. This is an example of a nursing assessment. Doing a full nursing assessment, if you had to handwrite that whole thing in narrative form, you would be with that patient all day long, and you're not going to have time for that. So generally facilities break the admission assessment form down by systems, maybe health patterns, functional abilities, health problems and risks. They use a specific nursing model, and it also depends on the type of healthcare setting. If there's a baseline assessment for a rehab center, it's going to focus on what the person has to rehabilitate. If it is a behavioral health facility, it's going to focus on that aspect of things. So it really depends what type of healthcare setting that you're working in, but most of them streamline the process by having a form that's similar to this. Nursing care plans always have, well, as per Joint Commission, if it's a Joint Commission facility, they want to see the nursing process. So this is just one example. There are different ways of having the care plans laid out, but you can see this one has the diagnosis, assessment, planning, a little bit out of order, but you get the idea. What's the intervention going to be? What's the rationale for that intervention? And then how are we going to evaluate? So they want to see, Joint Commission wants to see evidence that there's assessment. They want to see the nursing diagnosis or client needs, they may be called, nursing interventions, outcomes, evidence of a nursing care plan. It may be a traditional care plan written for each patient, but most of the time they're standardized because that saves time. So for example, if somebody has appendicitis and has their appendix removed, has an appendectomy, there may be a standardized care plan for appendectomy with room for writing freehand if there's a unique problem to that patient. But the standard of care is going to be similar between each patient who has that particular procedure. Makes it a lot easier. And flow sheets give us a graphic visual to see what's happening with the patient. So if you look up in the top area here, you see that there is a flow sheet for temperature. So the patient was admitted 319/11 and the temperature was almost 102, but look here, it shot way up, okay, to 104. So you can see on the graph, gives you an overall visual of what's happening with this patient. We use these for tracking urine intake and, urine output, comparing it to fluids that have been taken in, medication records, possibly skin assessment. So it's a quick area to write notes. And then a progress note may look like this, just a sheet of paper with lines where you write a narrative note. May include interventions, assessment, reassessment data, but you write freehand what happened to the patient. And this is often seen in conjunction with other types of records. For example, there may be a check sheet for an assessment and then progress notes to document anything that maybe is not included on your flow sheet or check sheet. Regardless of what type of charting system you use, always remember that it is a legal document and you've got to follow the guidelines for using it. So general guidelines for recording always include the date and time. You always document after you give care. So if you put a Foley catheter in, you document after you do it. If you give a medication, you don't write that down until after you've done it. And I know some of you who are nurses or CNAs or work in the field to some capacity are thinking, oh, I always document ahead of time. Don't do it. It can be a real headache if it would go to litigation. Or you document that you did it, somehow you get disrupted and you didn't give the medication or you didn't do the intervention that you documented, and then the patient doesn't get what they need. So you have to be very careful. If your handwriting, it should be legible. Luckily, we have electronic health records that have helped to eliminate that issue. It has to be permanent. You can't write in pencil or erasable pen. It's got to be permanent. Use accepted terminology that's agency approved. So you can only use the terminology that's accepted. You can't make up abbreviations and words. Make sure that you're familiar with the Joint Commission Do Not Use list, and that is included in your packet. So please look at that and make sure that you're familiar with what you can and can't use. Usually abbreviations and symbols, for example, greater than, less than, using the ampersand sign, are not permitted. So familiarize yourself with those kinds of things. Make sure you spell correctly, you sign, and that it's accurate. Are you documenting on the correct client's chart? If you document on the wrong person that you gave them Tylenol and then that person needs Tylenol, it's going to look like they already had it. Okay, that's just one example. Make sure that it's the right story, correct fact, and that you correct your mistakes appropriately. Different facilities have different policies for how you would correct an error. If it's something on a paper record, you're generally going to draw a line through the entry and write mistaken entry above it, or error. Facilities are starting to frown on the word error because it looks like you made some kind of medication error or mistake with the patient rather than just the mistake was what you wrote. So you may see mistaken entry. Then you're going to put your initials. You never erase, scribble out, or use correction fluid on these documents, ever. The original error must remain legible. Okay, so you can't erase it or scribble it out. Okay. And then the electronic health record should have some kind of correction software that goes along with the policy. So for example, there may be a strike through button that you push that will where the error will remain legible. So you probably won't be able to go back and delete what you wrote. Rather, you'll strike through it, put error per the policy of the facility. Here's an example of what I just told you. The patient complained of pain, left shoulder, complaint of pain of 0 to 10, and that was an error because the patient complained it was an 8 out of 10, but I can't scribble that out. So I would just put error or mistaken entry, then put the correct one. So here are some more do's and don'ts of documentation. Always make sure that you do chart any changes in status of the patient, good or bad. Show that you followed up. If you give a pain medication, that you went back and you asked the patient if they had relief. Read prior notes. Be timely, be objective, correct your errors per the policy. Chart any kind of teaching. Quote the patient whenever possible and review your own notes. Don't leave blank spaces because somebody else could come in and write something that didn't really happen, and going to court, that would be an issue. Do not chart in advance. Do not use vague terms. For example, the patient said it hurts. That's vague. We've got to put a number on it. The patient complained of pain, 8 out of 10 on a pain scale. Never chart for other people. You should always use the patient's name instead of saying patient stated. And the reason that they say that is because you could be charting on the wrong patient's chart. I personally have never seen anybody write the patient's name. I still frequently see patient or client, but it's something to keep in mind to avoid errors. Never alter the record in any way to make it look like you did something when you didn't, or that you didn't do something when you did. And don't record assumptions. For example, if you give a pain medication because the patient was complaining of an 8 out of 10 pain and you come back to check on them and they're sleeping, don't record that the patient's pain was relieved, because just because they're sleeping doesn't mean that the pain was relieved, okay? Instead, you would chart in your follow-up, return patient was sleeping. I'm not going to take the time to read these unedited documentation examples. They are in your packet and they are funny. So take a minute to read them, have a little bit of a laugh. These are actual unedited documentation examples from real patient charts. So be careful what you are writing. So I want to show you this legalities of documentation video. It's not to scare you. I just want you to understand, especially those of you who are not in the healthcare field at all, I just want to give you some examples of why documentation and doing it properly are so important.
Good morning. What I will be talking about this morning is documentation.
Sorry about that. I started it and I got to start it
and how
again.
the chart is used in the process of litigation. I'm also going to cover with you the reasons why patients or plaintiffs go seek out plaintiff attorneys to file litigation, and some of the factors that contribute to errors. We're going to focus a little bit on miscommunication and on delay in treatment. And then finally, I will wrap up with talking a little bit about computer order entry and give you some case studies that emphasize the importance of having clear and legible orders. The most common reason that plaintiff attorneys are contacted by patients or their families when there's a bad medical outcome is they want to know what happened. They can't figure it out. They've asked for an explanation. Maybe they didn't understand the explanation. Maybe they didn't get an explanation. They're looking for answers. And they believe that by contacting a plaintiff attorney and having somebody look at their records, they will find out what happened. At that time, the resident was told by the nurse and by the mother of the patient who was at the bedside that her daughter did not tolerate opiates well, but she had received Toradol in the past and had gotten a good response from that. The resident's response to the nurse and to the family was, "I'm the doctor. I know what I'm doing." And she left the Demerol order as is. What was key in this case was that there was an assessment form that was supposed to be completed by the nurses. They were supposed to evaluate level of consciousness. And you can see that it was done at 12:40, but there is no subsequent documentation of level of consciousness. When the patient had her arrest, there was a blood level drawn, and they found toxic levels of Demerol in her blood, to the point that it caused this patient to have a respiratory arrest, to be put on a ventilator, and then life support was withdrawn 4 days later. For example, it may happen like this. The nurses who work in the labor and delivery area have concern about changes on the fetal monitoring. But they were, in this particular case that I'm referring to, which was a North Carolina case, they were reluctant to talk to the obstetrician because he had a response that was typically negative when nurses approached him about concerns about a patient. So they did not approach the physician, and there was a bad outcome with the infant, and there was a $1.2 million settlement. A study that was done by the Institute for Safe Medication Practices focused in on how frequently this is occurring and discovered that when about 2,000 healthcare providers were surveyed, that the problem was much more pervasive than they realized, with the majority of people saying that they had not clarified orders for medications, for example, because they were intimidated by the response that they were likely to receive from a particular provider. I'll give you an example. I've reviewed several cases of people who have fallen out of Hoyer lifts when nursing assistants were moving them. As they're swinging through the air, they get dropped onto the floor, usually resulting in a fractured hip or a subdural hematoma. Nursing assistants, in at least several of the cases, were afraid that they would get in trouble by saying what happened. So they did not report the incident. The nurse who was evaluating the patient detects that the patient's complaining of leg pain, the leg is externally rotated, it's shortened, it's causing all kinds of concerns about what happened here, but the medical record has no information about it. So in that instance, the plaintiff attorney could assert that there was a cover-up of the original injury. An interesting note that I once found in a nursing home record was an entry that said, "Please leave the 3 to 11 shift enough room for documenting the fall when they rewrite the nursing notes." That's considered tampering with records, and in that case, the suit was resolved even before it got filed. This is an order for cisplatin, and this was a case involving a 9-month-old infant who was supposed to receive 20.4 milligrams. Got 204. When the order was transcribed, the decimal disappeared. When the order went down to the pharmacy, there was a warning on the cisplatin that recommended double-checking any dosage that would be in this level. 2 people checked the order but didn't pick this up and supplied it to the nursing unit. The child received the chemotherapy and died 2 days later, and when the autopsy was done, they found toxic levels of cisplatin in his blood.
It was important to us at our hospital to have our clinical staff educated regarding the impact of their documentation to future potential litigation. We asked Pat to come and address our staff on her experiences as a legal nurse consultant and basically give us some insight into how our documentation can protect the healthcare provider.
So those were just a few major examples of what can happen when documentation is not properly done. Now, with electronic health records, we have eliminated a lot of the issues because of illegibility, but there are certainly other issues that can occur. I am actually going to do a separate podcast for reporting because otherwise it's going to be way too long. So this way you can finish this one and move on to the next one. So your PowerPoint that you have continues on with reporting, and I'll just pick up there in the next podcast.